Asthma is a heterogeneous disease characterized by chronic airway inflammation, and it is defined by a history of respiratory symptoms such as wheezing, chest tightness, shortness of breath, and cough that may vary over time, like mostly it occurs during the night or early morning. So, asthma is usually associated with airway hyperresponsiveness and airway inflammation. Asthma, in asthma we have a triad of these three features like airway obstruction, smooth muscle hyperplasia or hyperactivity, and third is inflammation. These are the three basic pillars of asthma. And how asthma is different from COPD is COPD and asthma both are chronic diseases, but COPD is non-reversible and asthma is a reversible disease. So asthma also can be phasic. Like a patient comes to you that he will complain that I am having this allergic reaction or these symptoms, and then may become okay, and then again he will have this late phase reaction. So that is why asthma can be phasic. Asthma can be atopic or extrinsic asthma, and it can be non atopic or intrinsic asthma. Atopy is a predisposition to overreact to environmental allergens to which normal patient does not react. Familial predisposition to the allergy. The patients with atopic asthma have a familial predisposition to allergy, dust, example, dust, pollen, or animal danders. And in non-atopic, the causes for non-atopic asthma are aspirin or other drug-related like beta blockers, exercise, stress-induced, cold air-induced, and occupational toxins. And it can be other drugs-induced also. The most common symptom that the patient will with which the patient will present is the persistent dry cough, and the other symptoms are shortness of breath, chest tightness, and expiratory wheezing is when air passes through a inflamed or hyperplastic airways. It produces an added sound with in the form of wheeze. For the diagnosis, we have a gold standard investigation, which is PFT's pulmonary function test. So in a patients with the age more than 5 years, we can perform this pulmonary function test. The first is spirometry, and the other tests are other bronchial provocation tests. In spirometry, what we do, we ask the patient to take a full breath and then exhale through mouth. So into the device, it detects that how much a person can exhale and with which speed he can exhale. So if the patient is having asthma, then that patient could not be able to exhale properly because there is obstruction to the airways and there is a bronchoconstriction. So the forced expiratory volume that we call as FEV1, and it will be less than the normal patient. So we can also calculate the ratio, which is FEV1 by FVC ratio, and it will also decrease in the cases of asthma in a patient with asthma. So sometimes patient come to you that I am having these symptoms, but when you examine the patient, the chest will be normal. So it occurs because this asthma is a reversible disease. So we cannot find any finding in those patients because at that time he is normal. Children can have asthma, but it is treatable, and as actually it is a hyper response of your body to the allergens. So it will settle down as the age will be increasing. So but we need to treat them as soon as we can, because if we not treat, if we'll not treat the symptoms, or if we'll not treat the asthma in children, then there will be permanent inflammation of the airway which will keep going. It is an exacerbation of asthma which is unresponsive to the standard bronchodilator and steroid treatment. So, how the patient will present when he or she will have acute attack of asthma? The first is acute breathlessness and wheezing. The patient will present with this acute breathlessness. So, how do we assess the severity of the attack? In a severe attack, the patient will be unable to complete the sentences in one breath, and the respiratory rate of the patient will be more than 25 per minute, and the pulse rate will be more than 110, or he or she will have tachycardia, and peak expiratory flow rate will be 32 to 50% of the predicted. And it can be life threatening if the patient will present with the exhaustion, confusion, feeble respiratory efforts, silent chest, and arrhythmias or some ECG changes or hypotension. And ABG may was suggestive of high PaCO2 with the CO2 retention, and saturation will be less than 92. In these cases, the patient may need ICU care and may need ventilatory support. The first of all, supplemental oxygen to maintain saturation of 94 to 98%, and we'll start the nebulization with short-acting beta agonist. If the patient is responding to this treatment, then we'll keep him in for the few days in the hospital, and then we'll discharge him on the multimeter dose inhalers or MDIs, and on the oral corticosteroids. But if patient is not responding to the treatment, then we'll have to shift the patient to ICU, and we'll give the IV steroids, and we'll give the nebulization for certain days. And if the patient is retention having CO2 retention, then that patient needs to be treated with the non-invasive ventilation or NIVs. But if the patient is having persistent hypoxia and CO2 retention, then that patient will need the mechanical ventilation. According to classification, the asthma can be intermittent asthma or persistent asthma. The intermittent asthma will have a symptom frequency of less than 2 weeks, and waking up at night of less than two per month. And patient will use the short-acting beta agonist less than 2 days a week. And the lung function will be FEV1 more than 80%, or FEV1 by FVC ratio also will be 80%, more than 80%. And patient may have exacerbation less than 1 year. These are all the features of intermittent asthma. But second one is persistent asthma, and according to the severity, the persistent asthma is divided into mild, moderate, and severe. In mild persistent asthma, the patient will have symptoms more than 2 times a week, and he's waking up at night for 3 to 4 times a month. And the FEV1 will be more than 80% of predicted. And in moderate persistent asthma, the symptom may occur daily, and waking up at night can be more than one per week. And FEV1 will be 60 to 80% of predicted. And in severe asthma, the daily symptoms occur, and patient is waking up at night every night, and there will be extreme limitation of his daily activities, and FEV1 will be less than 60% of predicted. So treatment we will give the treatment according to this grading. In mild persistent asthma, patient will need low dose ICS. So ICS will reduce the inflammation, and the long acting beta agonist will reduce the bronchoconstriction. So they need to be given both together. And in severe persistent asthma, daily symptoms occurring throughout the day. So we have to treat it with ICS, inhaled corticosteroids, plus long acting beta agonist and long acting muscarinic agonist. First of all, we need to review the medication for that. Like we have to stop beta blockers if patient is taking any beta blocker or NSAIDs, any painkillers. And we advise the patient to avoid allergens, and we have to keep check that patient is regularly using pillow covers and bed sheets. Pollens, he should stay away from the pollens or plants. And the dust mite allergy, which is a very common allergy in children. If your child is waking up at night, midnight or night, he might have a dust mite allergy. So we advise those parents to continue with using the blankets and quilts with the cotton cover over it. And last is smoking cessation. The patients with smoking are at the more risk of developing asthma, so we advise the patient to quit smoking, and also the family members to avoid the passive smoking. There is a misconception regarding inhalers, regarding using in children and even adults also. The inhalers are the best and the foremost treatment for asthma. So they are not having any addiction issues, or there no dependence issues. So this needs to be addressed, that inhalers are safe in children and in adults also. And there is a proper technique to use the inhalers. Like your doctor or your physician will guide you that how the properly inhalers can be used. If a patient is not able to inhale properly, advise the patient a spacer device to use along with the inhaler. Spacer will act as a reservoir, that if you are not able to inhale it in a single breath, then the spacer will help that it act as a reservoir, and you can inhale 5 6 times out of that spacer.